I can see there's already 100 and something, but the numbers are climbing. Whilst you all filter in, I'd just like to introduce a couple of things and some housekeeping rules to you. My name's Barney Green, and I'm one of the regional surgical advisors for the Royal College of Surgeons. And also with us online is David O'Regan, who's going to take us through the management of pneumothorax and the chest drain in just a moment. Now, we have to just say a big thanks to the college for hosting this and arranging the platform for you all to have these educational seminars during this unprecedented pandemic that we're facing right now. A couple of housekeeping rules. First of all, you are free to send in your questions via the chat function. As the moderator for the talk, I shall try and answer the questions that I can. And those that are most popular, so you can like them, the ones that are the most popular, then we can pose to Mr. O'Regan at the end. Now, obviously, if 200 of you ask questions all at the same time, which in my experience you do, I won't be able to answer them all. So I don't want to disappoint you, but if you could keep your questions focused actually on the subject at hand, that would be most grateful, and I will do my best to answer them all for you. We have about 20 minutes of the lecture and then some time for questions thereafter. The last point of housekeeping is that if you were to tune in at the same time on Thursday the 21st, Mr. Colin Weir will be taking you through the anatomy, pathophysiology, and the management of hernia. Okay, I'd like to introduce David O'Regan to you. He's a consultant cardiac surgeon in Leeds. He's been in practice probably longer than I've been alive, or certainly practicing in my own career. So what he has forgotten already about the heart and the lungs, I don't think I will ever get to know. He has a huge portfolio and commitment to teaching, being the surgical director for the Faculty of Surgical Trainers. He's heavily involved in teaching in many different aspects, as well as being a regional surgical advisor. And if you want to tune in later on to his other passion, and that is his Black Belt Academy of Surgical Skills, I'm sure he could tell you about that later on. David, over to you, please educate us on pneumothorax and chest drains.
Well, thank you very much, and good afternoon to everybody, and thank you for the kind introduction, Barnaby. I want to keep this straightforward. We start off with an X-ray that, in simple terms, one should never see. This is a tension pneumothorax. You can see the mediastinum is displaced way across to the left. And with the superior vena cava and inferior vena cava fixed posteriorly, you can see this will reduce venous return, leading to shock, obviously tachypnea, tachycardia, cyanosis, but this is a near fatal presentation. And the saying is, one should never see this. If suspected, the quickest and easiest thing to do is to put a vent flange in the second intercostal space, mid-clavicular line. And there should be an explosion of air. Hopefully, you will never see this. So we start off with all basic things by understanding the anatomy. And it's important that you know the surface anatomy of the lungs, that the pleura are above the clavicles. Come down to the midline, in the sternomanubrium joint. On the left, it deviates to the heart, and then from the 6th rib anteriorly to 8th rib, middle axillary line, 10th rib, and the 12th rib posteriorly. The lungs in their development bud out into the mesenchyme, and in doing so, form the pleura, which is on the surface of the lung, in the lobes of the lung, and covering the chest wall cavity. And it's this space is the pleural space. The other thing to remember in simple anatomy is that your diaphragm is dome-shaped. So if you look at it laterally, it is like an inverted J, with the right hemidiaphragm higher than the left hemidiaphragm because of the liver, but you can see anteriorly, it's at the bottom of the xiphisternum coming up to T4, the central tendon, but extending all the way down to T12. And it's important to remember that there is this dome-shaped space because of complications of chest drains. It's useful to remember the physiology, that as the lungs move up, there's a pressure inside the lung decreases as the lung volume increases. During inspiration, the pressure increases during expiration, and the pleural cavity follows that. The pleural cavity pressure becomes more negative as the chest wall expands. I haven't put up a full respiratory volume curve, but for normal regular breathing, breathing in, breathing out is about 500 mils. And you can imagine it doesn't take much, therefore, to reduce your tidal volume and make breathing difficult. With diseased lungs, a volume of a pneumothorax of just 200 mils can compromise your breathing. In surgery, the commonest causes are from central lines, particularly on the right-hand side, and as I pointed out, the pleura comes above the clavicle. That is why anesthetists are now recommended to use ultrasound-guided control rather than go in with a needle and probably puncture the apex. Chest injury, sharp or blunt, can also cause pneumothorax, and trauma centers are trained to put in chest drains immediately before they even go to CT scans. Lung disease, chronic obstructive airways disease, bullae, fibrosis, pneumonia, TB would also cause it. And the idiopathic are little blisters at the top of the lungs, usually in tall, skinny adolescents, rupturing and causing pneumothorax. We use ventilation frequently, and our post-operative patients require ventilation, and with diseased lungs and with COVID about, positive pressures used frequently, and that will cause a pneumothorax. In otherwise well people, a small pneumothorax will either resolve or can be treated with simple aspiration. But in somebody who's symptomatic, who's very short of breath, tightness in the chest, problems with breathing, you need a chest drain. There's only one safe place to put a chest drain, and that is in the safe triangle. It's above the fifth intercostal space, which is in line with the nipple, behind the lateral edge of the pectoralis, in front of the latissimus dorsi, and below the base of the axilla. You go into there, you enter the axillary vessels and veins. I remember in my FRCS, I explained this to the examiner. He said, yes, where else could you put it? And I said, well, I could put it in the inclavicular fossa. He said, where? I said, no, not there, mid-clavicular line, second intercostal space. Because if you go immediately below the clavicle, you will be into the axillary vessels and the axillary bundle. The problem is, with a chest drain anteriorly, you're going through the pectoralis muscle. It's painful, it fixes, and it scars. So for medical students, this is the safe place and the only place to do it. This is a sterile procedure. You've got to confirm the diagnosis. And one of the things I've found with medical students that are percussion and tactile vocal phlebotomists are clinical skills that are not practiced. This is effectively clinical ultrasound. And if you suspect a tension, deal with it there and then, and do not do a chest x-ray. Otherwise, always get a chest x-ray. Now, it's important in people with chronic obstructive airways disease to even get a CT scan, because you might not be looking at a pneumothorax, but a large bolus. Remember to consent the patient, lay them flat on the bed, make sure they're comfortable. To make sure you're comfortable, pump the bed up so it's at a height you can work at. I was chatting to Barney earlier about marking the skin and sites. This is my little trick here. It's a pressure pound coin on the skin. And over the area at the fourth intercostal space, mid-axillary line, and even when prepped, that indentation will not go away. But it's also very useful because that is the area that you need to fill with local anesthetic, because putting in chest drains is extremely painful. And it's 3 milligrams per kilogram of lidocaine, up to 10 mils, provided they're not allergic, of course. you do have to remember that the skin and the parietal pleura share the same nerve supply. So when you put with an orange needle a bleb of local anesthetic in the skin, swap it to a green needle, fill that whole area with local anesthetic, and then go and perpendicularly immediately above the rib, aspirate, inject, until you reach the pleural cavity. Confirm the diagnosis because you'll aspirate air. Pull the green needle back a bit till you don't, and then put a lot more local anesthetic around the parietal pleura. If you do not get air back on the green needle in the place that you have properly marked and you've confirmed a diagnosis, do not proceed any further, because clearly there was something wrong with the diagnosis or there's something else involved. Go away and wash your hands at this point and scrub up, because it is a sterile procedure. And by doing so, we'll give you 5 minutes to 10 minutes for the local anesthetic to work. Too often we put in local anesthetic and proceed to try and put an instrument through the skin and wonder why it's causing the patient pain. Ensure that you have all the equipment to hand, and it's probably useful to have a second assistant. You'll need a drain, underwater seal, 11 blades inside the skin, and the most important tool is a blunt hemostat. Because once you've made a good full thickness skin incision, and the width you need is that width of the pound coin, again the little trick, you take your blunt hemostat and you split the muscles immediately above the rib. And you split the muscles this way for the external oblique, this way for the internal oblique, and you're above the rib because, of course, the intercostal bundle is sitting in the ridge of the rib above. You enter the pleura. You never ever use a trocar. You enter the pleura and you can put your baby finger in, or if you've got small fingers, you can put your finger in and confirm that you're inside the chest. Now, you think that is a bit much. If you've got diseased lung, and the COVID lung in particular will be wet and soggy, it is very possible to even put a chest drain directly into the lung without a trocar, because it'll be that friable. In trauma cases, I have actually put chest drains in and put my finger in to feel the stomach or the small intestine inside the chest where the diaphragm has ruptured. It's a bit like general surgical principles. If you don't put your finger in it, I believe you put your foot in it. You slide the drain in. To help, you may put the hemostat in the last hole, direct it in, and either push it in, up, or push it down. The placement doesn't really matter that crucially because you're draining the space. As I said, be careful that some people with lung disease could have a big bullous. And I explained the problem with trauma, the ruptured diaphragm, the liver might be in the chest, stomach, and I've seen small bowel. If there is a problem, please do not persist. Ask a thoracic colleague for advice. Now, the very important thing is the problem with a pneumothorax is a closed system. If the systems are closed and there's an air leak, this develops into tension. So under no circumstances whatsoever should you use a chest drain. You put the drain in. If it's open to the air until you connect the bottle, that's fine. It'll sort itself out when you've connected it to the drain once you've tied the drain in. This is a simple list of all the problems with chest drains. The commonest one, of course, is the side port sitting on the outside, and you get profound surgical emphysema of the chest. But I've seen this all. Massive bleeding, intercostal nerve injury, lung lacerations, splenic injury because people have gone too low. Remember the dome of the diaphragm. You name it, chest drains can be dangerous. Now, the management. Most my thoracic colleagues complain that they see complications of the management of chest drains. People do not tie it in the right place, put the tie on the dependent part of the drain, so it's not pulling from the top. It's useful to have a simple interrupted suture through the skin to enable people to close when removing it. Once you've secured the drain, connect it to a suction system. The suction system of 3 parts: the dry suction control, a water seal, an air leak monitor, and then a reservoir that collects fluid if there is any. Put a simple dressing around the drain. Simple piece of gauze cut into the shape of Y with a piece of tape. Too often I've seen reams and reams of sticky elastoplast put on the side of the chest. That in itself will reduce chest expansion and actually prevent breathing. But worse than that, the sticky elastoplast is a perfect site for Staph aureus infections. Simple dressing will enable you to look at this site, look for any discharge or any infection. A normal drain will gently swing with the respiration. There will be an air leak, and when the air leak stops, it suggests that the lung is inflated and the leak has stopped. When moving the patient to another department, again, please do not ever clamp the chest drain. I've seen people transferred from other hospitals, trauma cases, with clamps on the drain. Potentially very dangerous. Obviously, the bottle should be below the patient, but if the bottle is above the patient and the fluid goes into the chest, well, it's a sterile system. Never mind, don't panic, just put the drain back on the floor and it'll sort itself out. When do you remove it? You remove the drain when the air leak is stopped and the lung is up. When the air leak is stopped and the lung is up, take it off suction, wait another 24 hours, have another look, get the patient to cough, no air leak, you may proceed to remove the drain. The simple fact that the drain is sat in the pleural cavity for 48 hours or more, it causes a pleurodesis, and that in itself will perhaps cure the problem. I see the British School of Nursing suggests clamping the drain before removal. That is just to make it easier to remove. But again, beware of the clamps. Ideally, you want a Valsalva to take the drain out. But to instruct a patient to Valsalva is sometimes awkward. Remember, this can be painful, so do give them some oral analgesia beforehand. So either Valsalva, full expiration, pause your breathing, pull the drain out, having cut the tie and suture, pull it out, and pinch the skin together with your fingers, lift the suture, and then tie it. But do not tie it too tight. Do not ever put purse strings in. The number of chest drains that I see converted to what looks like bullet wounds rather than simple linear incisions is enormous. That is it. If in doubt, call a thoracic surgeon. Remember the safe triangle. Never use a clamp. And remember, it's a painful procedure. Lots of local anesthetic and blunt dissection only. Over to you, Barney. Barney, you muted?
Muted, there we go. I'm back online. Sorry about that. Thanks ever so much for taking us through those slides, David. That's some really excellent practical advice. Now, there have been lots of questions coming in, and some I've tried to answer already, but some I'm going to defer to your expertise here. And then the rest we'll try and answer. The first one, which got a few likes, was the question of how would you manage a pneumothorax if you were on a long-haul flight? Because I know that kind of makes the sensational press. So to give us a quick answer of what you might do in that circumstance, David.
Well, confirm the diagnosis.
Yeah.
Percussion. Practice percussion. Remember, your finger comes down and strikes the middle of the other finger on the chest. And if you can hear that, people who play the piano are more adept at that, but the finger should strike, middle finger, and there should be a nice resonance. The pneumothorax is bigger the other side. The case you're probably referring to, somebody actually used a pair of scissors. Remember that alcohol, 70% alcohol, is a good sterilizer, or even flame traditionally, but alcohol. Use a pair of scissors to open up the layers, blunt dissection only, not sharp scissors, and use the end of a pen, preferably a metal pen. You can put a pen in to drain the hole. With that in, you have to tie it in, and then create a flap. Put a dressing over it, tape around 3 sides, and you've created the flap. So air can come out, but won't be sucked in. And that's good as a Heimlich flap. And some people can be discharged from hospital with such a valve and not necessarily underwater seal. The story I heard was on a British Airways flight, and the person who did it actually got free flights for the rest of the year.
Well,
but remember, you could cause more harm by not doing it properly.
Okay. Okay, thank you, David. There were a couple of questions about terminology, the difference between thoracocentesis and thoracostomy. And I've tried to explain that, well, the actual word centesis, that comes from the original Greek, which really means to prick. So in a thoracocentesis, essentially what you're doing is you're pricking, in this case, the pleura to release air or fluid. Less favorable for fluid, to be perfectly honest, because if it's blood, it's thick and it will clot and cause problems. And a thoracostomy is, we're using that word stoma again, which is an opening to allow toileting, traditionally is the teaching there. So, don't get confused. We're talking about chest drains here, not needle thoracocentesis.
Some pneumothorax can be aspirated.
Yes. So that became a question actually from.
I have seen patients on ECMO with severe lung disease and an interstitial pneumonia like COVID, and with positive pressure ventilation, small pneumothorax of 150, 200 mils might be enough to actually compromise the ventilation and breathing. And in those circumstances, CT guided identification of the site with X marks the spot is useful.
Yeah.
But must be very, very careful, because you have to use blunt dissection. The finger needs to gently go inside the chest and make sure that the lung is away. Because in these circumstances, and this should be done by thoracic surgeons only or experts, because the lungs are so wet and soft, the chest drain itself can kebab the lung. And then you've got a bigger problem.
Okay. There's been a very popular question that at least 7 people have liked. And this is a question about doing needle thoracocentesis over the safety triangle instead of the second intercostal space in the mid-clavicular line. Do you have a particular opinion on that one, David?
Yes, I would always do it in the safety triangle. Okay. I'd always do it in the safety triangle. But sometimes if the patient is, I've seen it once in my life actually, that's, as you said, 20 years of 30 years of cardiothoracic surgery, seen it once. Somebody was prostrate, was about to expire because of a tension, and I put a Venflon in the second intercostal space, mid-clavicular line, and like putting in a Venflon, and then took the needle out. And there was a whoosh of air, and then I had time to actually put a chest drain in. But the safest place is always the mid-axillary line and the triangle between pectoralis and lat dorsi.
And could you recommend a gauge of needle or a color of Venflon, assuming we all use the same color Venflons?
Yeah, whatever's to hand.
But bigger is better.
No, it doesn't have to be big or brown for air, not at all. A green Venflon, gray one, brown, whatever's to hand, just to relieve that tension in that emergency circumstance.
Okay.
Some people go through their careers with never seeing this.
Yeah. Okay, another popular question is about volume of fluid to be drained out of the pleural cavity in one go. So the question is, we've been taught not to drain more than a litre and a half of fluid. Is this evidence-based or just teaching passed down from generation to generation? Which is not actually a bad thing, by the way, to hand down education like that, I should add.
The theory is that taking out a large volume of fluid will in fact cause a shift in the mediastinum. Now, this is the only time that a chest drain would be used by thoracic surgeons who have done a pneumonectomy and left a drain in. 500, if there's a few hundred mils, it's planned. But with an empty space on one side of the thorax with no lung there, you wouldn't want to drain a large volume. With a very big effusion, there shouldn't be much in the way of a shift. And I know it's traditionally taught, drain 1.5, wait, and then drain some more. The worry is about the mediastinal shift. But you would have seen that on chest x-ray anyway.
Yeah.
So the only people who should be using chest drains and monitoring the volume and clamping to prevent the shift would be thoracic surgeons only.
Okay.
Post-pneumonectomy.
Brilliant. Now, there's a couple of questions that I'm going to try and link all together, 3 or 4 questions on the same theme. The first one is, how do we know we've not actually injured the lung? And I think, if you've been listening to what Mr. Regan's been saying, it is down to your technique, making a hole, putting that finger in, because your finger is a soft and very blunt instrument, really, and carefully doing a finger sweep. It is through practice and excellent surgical technique that you don't cause unnecessary trauma.
Right.
But the question is then, how would you confirm that the chest tube is in the correct position, firstly? And then post-insertion, are there any particular things you must do? And then post-removal, are there any things you must do, for example, chest x-ray?
Yeah, a chest x-ray in both cases. Once inserted, do a chest x-ray. It is possible to direct it up or direct it down. Even though it's soft, it is possible. But a chest x-ray to confirm the chest, the drain's in the right position. But more importantly, that all the holes of the chest drain are actually sitting within the chest wall. This is sometimes particularly awkward if the person's particularly big or obese.
Yeah.
There's just another caveat to the blunt dissection. Just be careful of people who've had thoracotomies of surgery or pleurectomies in the past, because there won't be a pleural space. And if there is a pneumothorax, and there is a history of that, it's probably best, again, to get a CT scan and get the radiologist to directly identify where that is, or even the invasive radiologist could put a simple Seldinger drain into there under CT guided control or ultrasound control. But that wouldn't be in the remit of a new chest drain, and I wouldn't advise anybody not trained or thoracic surgeon to do that without proper guidance.
A quick question that I'll answer is, can medical students do a needle thoracentesis? And the answer to that is both yes and, carefully. I think as trainers, we would always advise that you have a supervisor with you. But of course, if somebody is expiring in front of you from a tension pneumothorax, and you know what you are doing, then you have to read the situation. I don't think you should be walking around the wards with Venflons looking to, to practice because you might make a mistake.
Yes.
But most of the time, this scenario, your superior, whoever that might be, a registrar, will say, come on, we're going to A&E because there is X, Y, or Z, and under guidance, then yes, you can. David, we have about 30 seconds left. Could you just describe why the underwater seal works and how that expels the air? There have been a lot of questions about this.
Well, the air coming out goes to an underwater seal of probably 5 centimeters at the bottom of a bottle. And then you can provide suction on top of that or leave it open to atmospheric pressure. Yeah. But it effectively, being underwater, provides a one-way valve for the air to bubble out and then leave to the atmosphere. Nothing goes back in to the water.
You can't physically suck it up into the lung by taking a deep breath.
You can't. However, if transporting the patient and the bottle ends up above the patient, that water can go into the chest. I would say awfully silly.
Yes.
All right. because if it's a single chamber, it's potentially dirty. But most of the drains now have got 3 chambers where these are separated.
Yes.
Just put it back on the floor, it'll come out again.
Yes. Yes.
But just don't panic, Mr. Mannering.
And that answers the other question about clamping for transfer. Again, you know, you don't need to. It's an underwater seal. It's safe.
Never.
Yeah.
The problem is with clamping it, you change an open system, which an underwater seal system is open through the water to the air. Put a clamp on it. If there's a persistent air leak, you've changed it to a closed system. And during your transfer, the patient may tension and die. As far as I'm concerned, clamps should be banned from the wards and only used by thoracic surgeons. End of.
Okay, brilliant. David, thanks ever so much. We're going to bring this to a close now. I'm sorry if I couldn't answer all of your questions, but you know, if you need some more guidance on what attention pneumothorax actually is and so on and so forth, then your textbooks will answer you. This is really a practical discussion about the tips and tricks for that. So David, did you want to say one last thing?
Yeah, I would just like to invite you to my basic skills Facebook teaching this evening, the Black Belt Academy of Surgical Skills, on Facebook at 8 o'clock, where we reinforce the basics of surgery.
Yeah, brilliant.
Tonight's
Thank you.
all about scissors. Brilliant.
And on the screen now, you should see the title of the next webinar, which is on Wednesday at 4 o'clock, Hernias, Anatomy and Pathophysiology with the Principles of Management. And Mr. Colin Weir will be taking you through that. Thank you all for tuning in. I hope